everybody. Like at the onset, I first thank the Kerala Pharmaceuticals for giving me the opportunity to be present here this evening and be the moderator for the panel discussions which are we going to have. And right now, what is the time, sir? I think it's prime time show. I think that is KBC. You see KBC? One Badega Crorepati. Where people, participants come, they are made winners by the computer after the questions are asked. And here also we present the show where participants themselves are the computers. They are going to answer all the questions fired on them. And of course, they are already winners in their respective fields and have achieved laurels in their fields. And I'm sure what are they going to win? They are going to win the applause and your active interaction, applause and clappings. They are going to make their coffers of happiness richer. Am I right? So that will be their prize today. And I think they are going to transfer, there is no bank which is going to transfer any money, but they are going to transfer the knowledge in your banks and you will be richer, all of you. So everybody is going to be a winner in today's show, right? So I think nobody needs any introduction. Dr. Neelam Sodhi is our practicing gynecologist.
Hello. Well, thank you, Dr. Goyal, for finding the first question at me. You said that you are not Amitabh Bachchan, but you made me Sehwag. So, well, coming to the question,
Thank you.
Cardiovascular disease is the leading cause of morbidity and mortality in developing countries as well as the developed countries. And if you see at the modifiable risk factors for cardiovascular disease, the most important ones being diabetes, hypertension, dyslipidemia, smoking. I think diabetes is at a pedestal which is very high if you compare with the other risk factors. If you consider diabetes and dyslipidemia, I'll go to dyslipidemia first. Dyslipidemia, primarily what we are concerned is LDL cholesterol. So in diabetes, the LDL cholesterol, the morphology is totally different. They are small, they are dense, and this small dense LDL is very, very atherogenic, and this leads to cardiovascular disease. Obviously, there is increase in triglyceride also, and there is a decreased HDL in diabetics. Now, coming to diabetes and hypertension. Now, this, as you rightly told, that diabetes, India is going to become the diabetes capital. But I would like to add here two more things. India is going to become the diabetes capital. It is going to become the hypertension capital, and because of these two factors, cardiovascular disease, India is going to be a leader in among the I think the developing as well as developed countries. Coming to hypertension, vis-a-vis diabetes, when these two factors, these two risk factors are combined, the risk of cardiovascular disease doesn't increase by twofold, increases by manyfold because of the various risk factors which are clustered along with these two factors. As I told you about dyslipidemia also. So when we are treating hypertension in diabetic patients, we have to be very aggressive. In fact, the goals of treating hypertension have become less. When we say that the goals of treating hypertension in diabetes, the goals are very, very low. And we all have gone through GNC 7 and 8. The other risk factors, smoking, again, if a patient is a smoker and is a diabetic, the risk increases manyfold when these two risk factors are together. So coming to cardiovascular disease per se in diabetics, as intervention cardiologist, when we are dealing with coronary artery disease, the disease is more severe, it is more spread, it is multivessel, and sometimes doing an intervention or a CAVG in diabetic patients becomes a nightmare. Dr. Wonder knows this very well because the arteries are very, very small, diffuse disease, and sometimes to get a target is very, very difficult. So I think diabetes plays a major role in cardiovascular disease.
So, are there any special goals for diabetics? We were talking about the hypertension first. And have you any choices once you start with any medication? in diabetes?
Yes, very true. See that goals of absolute goals of blood pressure reduces. Normally, when we say within 140/90, and we try to bring the goal down. Normally, when the goal is 140/90 for other people, it is 130/80 for diabetics. As far as treatment is concerned, if the patient is a diabetic, the first choice of antihypertensives is inhibitors of ARBs. And there are some medicines like diuretics or beta blockers. They sometimes increase the glucose levels. So wherever possible, I mean, you try to start with ACE inhibitors, ARBs. They are the first choice antihypertensive in diabetic patients.
So, Dr. Wonder, like to add anything about it? So the carry-home message is the goals in diabetic for treatment of hypertension are different, and the better choice is either ACE inhibitors or ARBs to start with. Coming on to the next question, Dr. Malli, gastroenterologist. Sir, give your opinion regarding the gastrointestinal complications, especially with reference to GRD in diabetic patients. As a physician, I know oral hypoglycemic agents have quite two-fold higher chances of getting GRD diabetic patients than normal. So, what is your take on that?
I think as Brijesh has rightly hinted, if we see diabetes has become mother of all illnesses. And in our practice, if we see, I think 1 out of every 4 patients coming to GI clinics, they are actually diabetic patients. So diabetes play a very, very major role. And diabetes does involve every part of GI tract, right from mouth to anus. So there's increased instance of even gastroesophageal reflux disease, GERD, even diabetic gastroparesis, which is even more common. You go down the bowel, then there is much higher chances of the bowel alterations to diabetes patients, what we call the diabetic diarrhea or the constipation, and even a rising instance of chronic liver disease, primarily accountable because of diabetes and metabolic syndrome. So what we call is it NAFLD. So specifically, what Dr. Karamveer has highlighted is the risk of GRD in diabetes and the drugs, the OH. Per se, if we see the epidemiological data, GRD definitely is more common in diabetic patients, whether it is controlled diabetes and much more in uncontrolled diabetes. So possible factors could be either the reduced salivary secretion, the motor or the sensory abnormalities in the esophagus, the poor acid clearance in these people, the diabetic gastroparesis also contributing, and LES also being the lower esophageal sphincter being lax in these patients. So all of the figures are, compared to normal general population, diabetics have almost 2 times higher prevalence of gastroesophageal reflux disease. 1. But whether they're more complicated GRD, that means more stricture formation, more Barrett's esophagus, more erosive esophagitis, that possibly is not true. So it's possibly more reflux, but not reflux-related complicated disease in these people. As far as OHAs, whether metformin and those are concerned, again there's a small but definite chance of increased GRD, but that I personally believe in our practice is not a major issue we count. It's more uncontrolled diabetes, people not taking good drugs, which is accounting for those, lack of activity, people diabetic being obese, which itself is an independent risk factor for gastroesophageal reflux disease, being diabetic also. So these, I think, things are more important than the role of
in your day-to-day practice, the first line of treatment, what you will prescribe for such patients, apart from lifestyle monitoring for GRD in diabetes?
In that, the first will always have to be the lifestyle modification itself, which is a dietary control and being more proactive lifestyle. Weight loss will be very, very important, optimization of their body weight. And then, if the reflux is not getting controlled, still the first line, if the symptoms are significant, it has to be proton pump inhibitors or PPIs. We generally start with a once-a-day dosage in the morning time. Choice of PPIs, it could be anyone. So almost all PPIs, what we have seen and what trials have shown, they have a comparable efficacy.
So, diabetics are more prone to gastrointestinal problems, especially GRD, and PPIs are the treatment of choice. Dr. Kapoor, what are the strategies and challenges to prevent the development of asthma or COPD in cases of diabetes?
So, diabetes as such are more prone to infectious diseases as such.
So the tuberculosis and pneumonias are very common in these patients. So no doubt the COPD patients, they are more prone to diabetes, and as such also pneumonia and asthmatic patients also they are more prone to diabetes. This may be because of the low grade inflammation which is going on in these patients, because COPD is also inflammatory disease and asthma is also inflammatory disease, and low grade inflammation which takes place in these patients, that's also responsible for more diabetes seen in these patients. Secondly, whenever these patients they come in the say ICU, maybe a asthmatic is admitted in the ICU care, or respiratory failure is there in the COPD patient, they are also more prone to, due to the stress or due to the medicines we are using in these patients, they are more prone to the precipitation of the diabetes. So we are careful in these patients. So as we treat, whenever we treat these patients, then we have to take care of the control of the diabetes also, so that we can get the good results. Similarly, in say asthma and COPD, the pneumonias are very, very common, and they go into septicemia also. So in septicemia also we get the best results only whenever we control the diabetes along with that. Simply as said,
so that's one aspect, that people who are asthmatics or COPD and on treatment medication, they have more respiratory diabetes. On the other hand, those who are diabetics, obese people and all, do you have more difficulty in treating such patients who are already asthmatic or COPD?
Yeah. So the patients who are say obese and diabetic also, that it is very difficult to treat asthma in these patients. So because they need higher doses of inhaled corticosteroids and higher doses of say long-acting beta-2 agonists, and along with this they need additives, other montelukast and levocetirizine, and also not only pharmacological treatment, they also need non-pharmacological.
Weight
reduction is number one thing, because we have seen where there is morbid obesity, after bariatric surgery, they do very well, and asthma is controlled very well in these patients. Second is the diet control, mainly say saturated fatty acids and carbohydrates we discourage in these patients. So we encourage other things, and regular exercise is very, very important in these patients, so that they get good control of asthma in these obese and diabetic.
Thank you, Dr. So we have to be cautious and taking care of people who are diabetics and have respiratory problems. Now we have with us Dr. Hunjan, our orthopedic surgeon. Sir, what are the musculoskeletal disorders like osteoarthritis or osteoporosis common in diabetics, and what special care they need apart from general population?
Of course, like other systems, diabetes affects the skeletal system as well. And diabetic patients, they are more prone to osteoporosis. So we have to treat the diabetes at the same time when we are treating the orthopedic and osteoporosis. And next thing is diabetes, because of the arterial disease, when the disease is more, then you can lead on to diabetic foot. And this is a very, very dreaded problem, and we have to treat the diabetes before the development of these complications. Otherwise, many people land up in amputation, and these things are very common. Then other problems, like if you want to do some surgery on the diabetic patient, you have to control it. Otherwise, the risk of infection is manifold more than the other diseases. So we have to control the diabetes before we proceed for any major surgery like joint replacement or any implant and trauma. So if some patient comes with a fracture and it is a compound fracture and the patient is diabetic, the chances of infection in diabetic patient compound fracture, the chances of infection are much, much higher than a normal patient. We can leave the normal patient for a few hours, but if the diabetic patient is there, you have to close the wound so that it may not get infected. And like this, other you can say problems in diabetes. If you want to give even intra-articular injection, you have to see if the patient is not diabetic. And intra-articular injections, they can increase the diabetes to some extent.
Diabetics have more musculoskeletal and orthopedic problems.
Yes.
But as such per se, they are more prone to osteoarthritis and osteoporosis
Yes.
than the renal population.
Then
That's the carry-on message.
yes.
So for any surgeon or any interventionist, I think it's facing like first of all as a bouncer to a batsman.
Yes.
First you see a diabetic, isn't it?
Yes.
Okay. On a fast pitch. So now comes a very important aspect of diabetes, which is generally not very well understood, not given that much importance which should be given. That is the diabetes with pregnancy. So we have our expert Dr. Nilsody with us. I think not only gynecologists, general practitioners, physicians, everybody, sometime or the other has to see a pregnant patient, whatever specialty you are dealing with. And if she is a diabetic, then all the more you had it. So please pay attention to what he is saying. Thank you.
I think the message that I would give to a group of cross-disciplinary doctors who are collected here is that any patient who plans a conception, she might come to anyone for any complaint. So if she is planning a conception, it would be definitely better to have her blood sugar controlled even before they are planning to go in for the conception. Once pregnancy has occurred, at the very first visit, a blood sugar has to be done. It's not just about CBC and blood group and urine routine and a thyroid test. The blood sugar has to be done. In the first trimester of pregnancy, it's going to be very difficult for the patient if we think we can give her an OGTT or a glucose challenge test. She is not going to tolerate it. So the simplest thing to be done is to get a random blood sugar. And for those patients who have a family history of diabetes, we just tend to be a little more careful with those. So at the first visit, the blood sugar is done, and this is the first visit is the time when the patient needs to be explained that in pregnancy, irrespective of the fact that whether she has a family history of diabetes or not, she can develop gestational diabetes mellitus, and at the same time, once developed in pregnancy, this disease may continue to be a partner of her life in later years also. So the diet has to be very, very importantly emphasized, that the patient has to stay off saturated fats, keep low on sugars, take a lot of protein, and another very important message to be given to that pregnant woman at the exact first visit is the importance of exercise. Because it's not just about diabetes, it is about all the metabolic complications that she might develop in pregnancy, and this sort of has increased with the population that we are seeing more in private practice. If I were to be working in civil hospital, I would probably be seeing a different set of patients. But since we are most of us in private practice, what we see in our patients is definitely an increase in hypertension and diabetes. Another thing that I also want to say is that once that blood sugar has been done in the first trimester, a glucose challenge test, which most of us are following according to the DIPSI guidelines in India, is to give a 75 grams glucose challenge test between the 20th and 26th week of pregnancy. This need not be done fasting, and you do not necessarily have to have a fasting blood sugar done. This is to be done at any time of the day. As I said, not fasting, a 75 grams glucose and a 2-hour blood sugar test. The cutoff is 140, so anything more than 140 is GDL, and diet control is the best to advise according to the levels. Metformin has a role. Currently we are treating a lot of patients with metformin in pregnancy also, but it has a limited role, and insulin will remain the mainstay of treatment.
Thank you, Dr. Neelam. So carry-home message is that the values for declaring GDM are different from the person non-pregnant diabetes. So any fasting blood sugar in pregnancy 92 more than 92 and 20 more than 40 after 2 hour post-prandial glucose 75. This is different from ADA. Mind you, it's different from ADA and DIPSI guidelines. Are we safe legally for DIPSI guidelines in India?
Yes, we have had a number of studies on this, and most of us do prefer to go by the DIPSI guidelines.
Thank you. I have taken the liberty of disturbing our chief guest again and again, because my little introduction is that I am his class fellow only. So, final comments from Dr. G. Swandal regarding that non-coronary complications of diabetes as far as cardiology is concerned. Say cardiomyopathy, any comments or any rhythm disturbances or whatever you would like to say. Final word from Dr. Swandal.
I think we just learned from all experts that diabetes is a multi-system disease, and it affects, it doesn't just reduce your immunity because of which it bothers Dr. Hunjan. It also alters the GI motility, and so Dr. Mali has a lot of problems with his patients. It alters disease, it's a chronic inflammatory precipitant, so Dr. Kapoor has issues with it, and of course obstetricians have problems. And I and Dr. Brajesh Pradhan have, of course, the first thing that you ask a patient, resident is whether the patient is diabetic or not, because the whole approach changes once you have a diabetic with coronary artery disease, a diabetic with cardiomyopathy, as Karamveer asked, diabetes with hypertension. So diabetes is truly a multi-system disease, significant connotations, has microvascular and macrovascular complications, and end organ damage. We live in a country where the prevalence of diabetes in urban areas, there have been some ICMR studies which have shown almost 13 to 14% prevalence in urban areas and 7 to 8% prevalence in rural areas. In people who are sedentary, who are white collared, the prevalence even goes to 16-17%. So it is a disease which is very common, and because of a vast population today, we have almost 18% of the world population lives in India. So that's the reason we and Indians and Chinese form the largest number of diabetic patients. So I think very aptly you have highlighted in this multi-system expert panel that diabetes plays and affects other diseases to a very large extent, and thus impacts our mortality, our management protocols, that we have to be more aggressive in this. As far as my specialty, as Brajesh was saying, these people have bad vessels, they have other associates, they have cardiomyopathies, and so they have LV dysfunction. So a diabetic with acute myocardial infarction has almost 2 times the mortality than a non-diabetic. In fact, diabetes in our field is considered as a coronary artery disease equivalent. So if you have a person who has a known CAD and a person who does not have known CAD but just has diabetes, the risk of having a coronary event is almost the same. So that is the extent of its impact.
Thank you, Dr. Sri. So nice. Thank you very much. And now we have all the experts at your disposal. Any questions, any queries from the floor, from the audience? Before we conclude the diabetes part and then move on to the next topic.
But Karvi, I think I'll just take 1 more minute. So what Dr. Wanda also highlighted, one important thing which everyone in the audience should carry home message would be diabetes and liver disease. So we didn't touch upon because it was GRD. But most important thing is what I was discussing with my co-panelist, over huge paradigm shift as far as etiology of cirrhosis or chronic liver disease is concerned. 20 years back, the first question used to ask is cirrhotic, are you an alcoholic? Because alcohol used to constitute 50%. Then came Pepsi in Punjab, which became the first alcohol, came to number 2. Now in 2018, the commonest cause of liver disease in our part and world over is non-alcoholic fatty liver disease. It constitutes 40% of all cirrhotics. And the first question I think nowadays in our cirrhotics we ask, are you a diabetic? For how long you have been suffering from diabetes? Did you stay obese for long? So obesity and diabetes, which are part of metabolic syndrome, is the first and the commonest cause of chronic liver disease, cirrhosis. So number 2 would be Hep C, and alcohol is now number 3 in the map. So this is very, very important carry home message. Screen your diabetics for liver disease. Someone who is an established CKD, a good number of them already have a chronic liver disease also. So diabetes and liver possibly are the 2 sides of a coin, and we should not be missing those things in our practice.
Dr. Mali, I think you will carry on with the next topic, and it starts with you, only. What should be the management guidelines for inflammatory bowel disease with diabetes?
Okay. Inflammatory bowel disease and diabetes. Okay. So the IBD, I think, is again with a shift now. So IBD is two things: ulcerative colitis and Crohn's disease. Regarding guidelines, because the issue is if someone is diabetic, and one of the major drug for treatment is corticosteroids. And steroids, we know, actually worsen the underlying diabetes in these patients. All the remaining drugs, whether they are 5-aminosalicylic acids, even as a thioprin, they are much safer. So we tend to, if someone with an IBD comes to us and he's also a diabetic, our tendency is to avoid corticosteroids. But if it is a severe flare, we need to give. We try to give the safest possible steroid in these patients. And safest, many people believe possibly deflazacort is the safest, which possibly is not the true answer. The safest we have is budesonide, which comes as a 3 milligram capsule formulation, which is a minimum systemic toxicity. So the steroid of choice in an uncontrolled diabetic is budesonide. The starting dose is basically 9 milligrams per day. All other drugs, whether it's bisalon, that means prednisolone or methylprednisolone or deflazacort, toxicity-wise they are very similar. Rather, we feel methylprednisolone is a touch better compared to the side effect profile compared to other drugs. Regarding which drugs to give for diabetes in these patients, that's the other part now. So how we control, so we still go with the conventional drugs of metformin being the first choice. Now there's some data coming that the newer drugs, the DPP-4 inhibitors, in long term means people have been using for more than 4 years, there's a higher incidence of new onset IBD in those patients. So, but this, I think, once we use DPP-4 inhibitors long term, we need to see. In India, they are still newer drugs, but we personally believe they are again wonderful drugs and they should be used as commonly in IBD as in the non-IBD patients.
So, continuing with the IBD, so how the cases of IBD are managed in young females and who want to consult?
Let's see.
Be ready for that.
Again, this is very, very important because IBD is something which it's a bimodal representation. The first peak of IBD comes between 20 to 35 years. So that's the typical age where females conceive. The second comes at somewhere around 65 to 75 years. And the first is the tallest peak of inflammatory bowel disease. So the biggest chunk of our patients, they are actually in this reproductive age group. And the problem in females is when they are planning for conception, the right timing is when the disease is in remission. If the disease at a time of conception is in remission, the very high chance it will stay in remission throughout pregnancy. And if you take the other part, if disease is very active, very high chance the disease is going to stay active or even worsen during pregnancy. And if you take active inflammatory bowel disease, the risk of preterm babies, small for size babies, even the perinatal mortality, that risk actually goes up in this population. So the one message which we as gastroenterologists give to all our females who are contemplating pregnancy is first control your IBD well. Let this be in remission for minimum 3 to 6 months, and then that should be the time to plan conception. And if it is really active, then I think they are taking a big chance. Being flared-up disease, more number of drugs, and poor fetal outcome in these patients.
Would you like to add anything on it?
Yes,
Okay.
It's just that the male partner, if the male partner is being treated for IBD, then there can be certain sperm abnormalities. So as Dr. Malli has already said, it happens for both of them. If they are planning a pregnancy, then even the male partner needs to, I think, go off the medication for at least 3 months.
Because it is a reversible complication.
Yes.
Yeah, that's right. So, Dr. Kapoor, in the IBD, association of respiratory tract has been said to be associated with IBD, and radiologically, IBD mimics lung disease like tuberculosis, granulomatous, and pneumonitis. How do you diagnose?
So mainly it is the radiological diagnosis. So CT scan can, HRCT can pick up the mainly the interstitial lung disease, which is usually present in these IBD patients. And also it can pick up other, say, inflammatory conditions which are present, especially bronchitis is quite common in these IBD patients. So if they are symptomatic, then it's easy to diagnose these patients, but most of them are not symptomatic. Then CT scan can pick up these patients. And after the CT scan, we want to prove that it is the ILD or other, then we have to take the bronchoscopic biopsies also in these patients.
TB,
Yeah, Baki
transbronchial aspiration biopsy or HRCT, they are the two modalities.
Yeah.
And wherever you feel that patient is suffering from IBD and you have respiratory problems, then they are carrying a message to investigation. You should keep in mind.
Yeah.
And we all know, we have been seeing all the inflammatory disease, inflammatory bowel disease patients, and they have associated skeletal problems. So 30% of people of IBD, they are known to have skeletal problem issues with ulcerative colitis. So what special steps are to be taken in such patients? Your comments on that, please.
IBD patients, they are more prone to they are more prone to osteoporosis. So I think before we go in for any orthopedic problem, IBD should be corrected. We will like to send the patient to Dr. Mali before we treat, and this is the only step I can take. IBD should be corrected before we want to correct the orthopedic problems.
So final word from Dr. Mali. Please. Final word from Dr. Mali. Any patient, whether he wants to conceive or to get a treatment for chest problem or orthopedic problem, IBD has to be under control. And once patient is symptomatically okay, how long the treatment has to continue before person goes ahead with the next plan?
For new pregnancy or otherwise?
Otherwise,
the therapy of IBD practically is a lifelong therapy. So even
that's the carry home message.
this is very, very important. So people might take it with a pinch of salt. We have to be on drugs lifelong, but this is actually the truth in these patients, because moment they are off drugs, small percentage might do well in short term, but in long term everyone will come back with the relapse. So drug therapy, we need to do the safest drug, which could be possibly 5-ASAs. Steroids only short term to tide over the crisis in these patients. But therapy with 5-aminosalicylic acid needs to go lifelong. The question about osteoporosis, all these people, they need a yearly bone mineral density monitoring by DEXA, especially people who received steroids in the past. Disease and remission, we might do it once in 2 to 3 years, but with active disease, it has to be annual. And they have to be on vitamin D and calcium supplementation practically lifelong.
Thank you, Dr. Mali. Now again, any questions from the audience?
Actually, Dr. Brajesh Pradhan and I didn't like that you skipped us in this. See, inflammatory bowel disease is a systemic disease, and cardiovascular diseases are also systemic. So our patients have aortic regurgitation, they have mitral regurgitation, they have aortic dissections, they have aortic dilatations. And one very other important aspect is patients who have inflammatory bowel disease, patients who have rheumatoid arthritis, they have a pro-inflammatory condition. And we all know that coronary artery disease, besides its known atherosclerotic risk factors like what he narrated, diabetes, hypertension, smoking, positive family history, sedentary lifestyle, central obesity, there is an inflammatory element, because we know, in fact, we even tried some antibiotics and so many H. pylori was at one time brought, but that didn't get the proof. But we do know that inflammation plays a role in acute precipitation of coronary events. And in fact, it is said that people who have inflammatory bowel diseases, rheumatoid arthritis, they have 2 times the risk of coronary disease events than a person who does not have this disease. And so your threshold for using statins your threshold for controlling risk factors should be much higher, because the risk of coronary disease is higher in these patients with chronic inflammatory disorders.
You really enlightened, Dr. Wonder. So we have to take that into account always when we are treating IBD.
I think we can have the audience participation.
That's why I am asking any questions from the, or any comments from audience on the floor.
Question for enteric nervous system. So the second brain, which is our brain in the gut. So as diabetes does the neuropathy part, with the peripheral neuropathy, with the autonomic neuropathy, and with the biggest set of neurons are an enteric nervous system. So it is a form of intestinal enteropathy which manifests one or the other way, either with constipation or with diarrhea, or it could be an alternating constipation with diarrhea. So it depends on which set of neurons, rather like we have motor neuropathy, we have sensory neuropathy. So same part, the different set of neurons over a period of time they get involved in one form or the other form. So dictum now is someone who has a 10-year diabetes, his GI malfunction is going to be universal. The common we see in our practice, predominant is a constipation variety, but with long term, say 20 years diabetes, 25 years, there are more tendency from constipation going into diabetic health. So this is just the manifestation of the intestinal enteropathy which is manifesting in one or the other.
Can I make a comment, Karan?
Oh, sure.
Just as the nephrologists, they do kidney transplants, we have heart transplant, we have corneal transplants. Gastroenterologists are the smartest actually. They thought, what is an easy transplant? And they started doing fecal transplant now. So these guys, what they're doing is they have a safe procedure and they do this fecal transplant, and they even now, first they started with antibiotic induced Clostridium difficile, now they started using in inflammatory bowel disease also. And I was just reading an article in which the gut microbiota has been incriminated for diabetes and metabolic syndrome also. And in this particular study, they have done fecal implantations for patients with diabetes to prevent complications and to reduce So these people are now going to get into the gamut of others also.
I really applaud Dr. Wander's wealth of knowledge, because this is very, very latest thing. Fecal transplant people are contemplating for diabetes and its complications. And if gastroenterologists succeed, then diabetes possibly will be in our domain.
That's true. Fecal anything now.
I'll just...
Yes, Dr. Kanish, symposium, internet symposium in Gurgaon. Person from Germany, he had written the diabetologist, right? Yeah. He was a gastroenterologist. I was wondering how he is writing diabetologist.
All people who are from Germany, they'll write gastroenterologist and diabetologist. Yes. So, cross Germany.
Sir, this is for cardiologist Dr. Wander and Dr. Bhatt. In fact, I have read one article where they said there is an infective cause for myocardial infarction also in other cardiac events.
We all know atherosclerosis. We were at one time taught that there are 200 risk factors for coronary artery disease. And then this Interheart study came, which actually established that the 9 commonly enumerated risk factors can explain 95% of strokes and also coronary artery disease. We have an Interheart and an Interstroke trial. So we know what are the risk factors for atherosclerosis. But what we really don't know is, see, a lot of people here sitting have plaques, but whose ruptures, we don't know actually. We are aware of the fact that somebody goes to, for extreme physical exertion, someone has an extreme emotional stress, someone takes cocaine, cannabis, intoxicants. So there are some risk factors which are known for acute rupture of an atherosclerotic plaque. But what we don't know is why atheromatous plaque, and we know 70% of the atheromatous plaques, they rupture, that rupture and cause acute myocardial infarction. They are not obstructive plaques. And that's the reason interventions have not been shown to be of benefit in chronic stable angina, but they have been shown to be of benefit in acute coronary syndromes only. Because chronic stable angina essentially is because of a fibrotic plaque which is less likely to rupture and not going to cause an acute event. But what causes an acute event is a rapidly growing, rapidly increasing plaque which has a thin fibrous cap, a thick fatty core that it has. Now, what causes precipitation of rupture of an atheromatous? We know that it ruptures at its edges, we know it ruptures when they are fast growing, but what causes we don't know, and that's where this this inflammation, infection theory came. And as he was just saying, a couple of years back they were incriminating H. pylori for everything. Aajkal they कहते हैं gut microbiota नारी सारी बीमारियां उन्होंने decide. So these are things what you eat. Even Bhagavad Gita says what you eat. That is you are that kind of a human being. So infection theory could not get proven. Actually, people at one time thought that H influenza, these episodes of influenza, they increase acute coronary events. It does, but it does not explain the whole story. And no antibiotic, none of these agents have been shown to be of any benefit. But some inflammation role in acute coronary events is well known, Dr.
Empowerment sweeping across the globe, especially in our country. I think we go ahead with the pregnancy first. Is that okay? Dr. Neelam, what are the common metabolic complications observed in pregnancy for the audience in the floor?
I think we all know them and I don't really need to enumerate. So, maternal obesity in the current times is the leading cause of all complications, of all metabolic complications. So, we have hypertension, diabetes. Any patient who has obesity herself is going to also cause a lot of problems for the fetus. She will have an increased tendency to go in for a cesarean section apart from the diabetes and hypertension. And there is something called now this hypothesis of, the Barker's hypothesis of fetal origin of adult disease. This is what is catching on very strongly, that whatever the fetus is facing in utero, that lays the groundwork for the diseases that it is going to develop later on. So hypertension, diabetes mellitus, maternal obesity, and of course dyslipidemia, as you've already said. So these are the major complications that would occur. And these can lead to preterm labor, which is going to affect the fetus.
Thank you, Dr. Kapoor. What are the challenges in the management of asthma in pregnant ladies who is on antihypertensive agents, already on antihypertensive?
Yeah. So usually the severe asthmatic patient who are not uncontrolled, they usually get the preeclampsia and the hypertension. So these patients we have to treat very aggressively. You have to control the asthma, and the safer drugs are the same as we use in other population, non-pregnant. So inhaled corticosteroids and long-acting beta-2 agonist. Plus we can give antihistamines, safer antihistamines, that is cetirizine or with montelukast combination. These are safer. And these patients usually, whenever they get, say, uncontrolled hypertensive crisis, then the safer drugs in these patients is NTG. So nitroglycerin is the best drug to be used in these patients. So otherwise, say diferidine, long-acting, that is a good drug for usual treatment of
what
these patients.
What do you take on that? There was a controversy that even in eclampsia or pregnancy-induced hypertension, for control of asthma, low dose of steroids actually may be a beneficial.
Yeah,
Systemic steroids.
Systemic steroids. Systemic steroids, in uncontrolled asthma, we have to use these systemic steroids, and these are safer. These are not having any, say, malformation as was being thought previously.
Yes, that's what my point.
So that is the
for the floor.
Yeah.
Please go ahead.
So we have to give steroids in
as gynecologists, as obstetricians, most of us do manage PI, pregnancy-induced hypertension ourselves. If a patient has chronic hypertension, we would definitely take the advice of our physician colleague for that. Now, what we have also seen is that if the patient is coming into the OPD with 140/90, that is not the time to jump into antihypertensives, which is what most of us are commonly doing. White collar hypertension is well known. So the best thing is to have this patient be monitored at rest, maybe with a close by a general practitioner or somebody who, or even at home with a validated instrument. Only the correct time to actually start antihypertensives is when the patient is exceeding 160 and 110. This is according to most guidelines, that when the patient exceeds 160 and 105, that is the time to actually start antihypertensives. But we generally tend to do them at even lower levels of systolic and diastolic blood pressure. Another thing is that our obsession to bring the BP down to even a diastolic of 70. What is to be remembered is that when the blood pressure comes down to a lower level, the maternal as well as the fetal perfusion is affected. So it is not very important. The importance is to keep it between 120/80 and 160/100. So if the patient is at 140/90 with her antihypertensives and her platelets are normal, her LFT is normal, she may or may not have proteinuria, but she is otherwise okay. It is not necessary to bring it down lower than that.
So for the general masses, what is the first line of treatment in case you start with the antihypertensive drug in pregnancy? What is the first line of treatment?
The drug you are asking me? Currently, of course, we are using a lot of labetalol. Yeah, so methyl dopa was the mainstay till some time back. Although the dose recommended earlier was 250 TDS and now we tend to give 500 mg TDS. Postpartum alpha dopa can cause depression, so it was not used at that time. Labetalol to a maximum of 1.2 grams per day can be used, and of course since it is available in intravenous form also, so if the patient presents with an acute hypertensive crisis, this is a good choice to use. Hydralazine was something we were using when we were in medical college, and it was a fantastic drug, but it's not any longer available. Nifedipine, not to be used sublingually, which is what we have been doing throughout our medical college times.
There is a very important carry message, please take care of it.
Yeah, so labetalol remains the mainstay of treatment to be started in a BB dose, and as I said, it's not important to bring down the blood pressure level to a point where we might feel comfortable कि 120-70 है तो अब इसको कुछ नहीं होने वाला, but maybe 120-70 से हम ज़्यादा deterioration कर रहे हैं इस patient की, rather than keeping her at a 120/80 or 140/90.
Dr. Malli, as in diabetes and pregnancy also, people are more prone to gastroparesis. So any drug is contraindicated to be sponsored in pregnancy?
GRD anyhow is much more common in pregnancy in the population. There was a big concern again 20 years back that PPI is possible. Yeah. But all other, whether it's esomeprazole, rabeprazole, lansoprazole or pantoprazole, they're all category B. Category B means they are safe drugs, but you don't have large randomized controlled trial to substantiate. But the carry-on message is
omeprazole is C.
Yeah, omeprazole is C. So the carry-on message would be, if GRD is significant, so one should first try non-pharmacological methods, which could be again small frequent meals. Then before retiring to bed, at least one should take a night meal at least 2 hours prior. But if you want the drug therapy, then even PPIs now are the first line therapy. The choice could be anyone except omeprazole. But even omeprazole also people are giving in, there are hardly any side effects being reported. Single dose, morning time, and if you want to give a bedtime, so possibly then you can combine F2 blockers and they are going to have good results.
Even though the patient might not be complaining of symptoms, maybe 10 years past, if a pregnant woman was walking into our clinics and saying, "Mujhe jalan hoti hai," so we would be advising non-pharmacological methods. But this comfort with and the guidelines telling us that it is safe to use, the pharma companies are the ones who have benefited the most out of our prescriptions. Because I think it is so very easy to prescribe a pantoprazole or any drug and expect the patient to be comfortable. I think but this is leading to disaster because we are encouraging a tribe of women, young women, who are wanting to be so comfortable with drugs that they will not be able to actually accept challenges which a motherhood would throw up. So my request to everyone who is even remotely concerned with pregnancy in any way is to not give in to the temptation of prescribing drugs counseling, saying that this is going to be a normal thing, and as Dr. Mali said, frequent small meals, plenty of use of curd. अगर जलन होती है तो 2 चम्मच दही खा के देख लो, it might work the same way. And an active lifestyle, incorporating millets into your diet. Because I think we've not really brought that up, is that wheat causes a lot of it has a lot of gluten. And gluten is actually giving rise to a lot of glucose intolerance. Removing wheat from diet for all of us, irrespective of whether we have a disease or not, at least at one time during the day, and introducing millets, ragi, jowar, bajra, and any form of millets is definitely going to help us all lead a healthier lifestyle.
Thank you very much, Dr. Lam. It's a really good piece of knowledge for everybody. And finally, Dr. Wonder, please tell upon what are the cardiac complications, especially in relation to water allergy. And in short, carry home message.
I think she just gave us a carry home message that in pregnancy use as less drugs as possible, and only use drugs which are absolutely essential, especially in the first trimester, because some of these things can be handled by lifestyle methods. I just have a question for Dr. Mali. What is the reason PPIs have taken so much over the H2 blockers? Because H2 blockers came and they were so... When I was going through my initial medical education, and these were, at one time, Zintac was the most prescribed medicine in the world, and Lexotin. So what's the reason these PPI, and we have this fear of acid production being totally... So what's your current take as a test?
Yes, no doubt about it. 80s was all about H2 blocks, the potency. So when someone is suffering from reflux, even one dose, you take all the acid-producing pumps in the stomach. With a single dose, 99% of the pumps they get blocked. So what happens is, reflux suddenly is like a vacuum. Someone has sucked it up. With H2 blockers, the blockage of those pumps is in the range of 60 to 70%. So meaning thereby, with H2 blockers, a small amount of acid still being produced, which PPIs knock out completely. So what ma'am was telling is, people want complete. So possibly with H2 blockers, they were able to do a good job, but not the complete job. That is one. Two, with H2 blockers, tachyphylaxis sets in very fast. That means the tolerance of the body. Beyond 4 weeks, they start losing their efficacy. PPIs, someone takes lifelong, they will keep their efficacy. So, meaning one, non-development of tolerance or tachyphylaxis. With a single dose, the efficacy or response. These are two things which have shifted the whole balance away from H2 blockers and in favor of PPIs.
So, any questions, any comments from the floor, audience? Actually, your active interaction is their prize.
Yeah. What ma'am is asking is H2. Because what happens is, the PPIs are actually called the final common part. So whatever way the acid is produced, the eventual step, the final step is blocked by PPIs. H2 blockers, they only block 1 out of 3 major mechanisms. So even they block one, body very fast, the other 2, they undergo hypertension, something like that. And then they again start reproducing more. So they lose efficacy over a period of time.
So, coming on to the last but one topic. So, we will finish it in next 10 or 15 minutes. We won't keep you waiting for our dinner. So, finally, we come to on a long-term basis.
NSAIDs, of course, we are giving in routine, but they can cause a lot of gastritis, and probably they should be avoided where we can. They should be avoided, and I think it is more safe to give the NSAIDs with PPI. We always give NSAIDs with PPI because in orthopedics, rheumatoid arthritis, osteoarthritis, and other, even after surgery, we have to give NSAID for a long time. So normally we combine the NSAID with PPI so that patient doesn't get distress and other complications.
So are there are any interactions with the cardiac drugs? Patients on the cardiac drugs?
Yes, of course. I think cardiologist can give more information on that.
Dr. Badal?
Well, coming to NSAIDs, I would like to focus here on COX-2 inhibitors because they are now being more commonly used. And COX-2 inhibitors, they inhibit the cyclooxygenase enzyme and inhibit the production of vasodilator prostacyclin. And second, it also inhibits the eNOS, that is E-nitric oxide synthase. So these are two very important vasodilators. So because these two are inhibited, sometimes they paradoxically increase the thromboxane also by alternative pathways. And this can lead to coronary artery disease, rather cardiovascular disease per se. Second thing is if you use NSAIDs. NSAIDs, they cause sodium retention. And patients who are hypertensive, they can have elevation or increase in the blood pressure, and they might need a ventilation of the therapy. So these are the two main effects of
So any patient who is taking long-term NSAIDs is hypertensive, his her dose has to be increased, and we have to take into account, be careful about COX-2 inhibitors. Poor patients on NSAIDs with COPD or asthma, what is take your answer?
We avoid NSAIDs, especially in asthmatics. We don't know the patient will react, how patient will react. We usually try to give, say, mainly acetaminophen in these patients. And second is tramadol plus paracetamol combinations. These are safer as far as asthmatics these patients are concerned.
So if a patient is receiving intra-aortic corticosteroid, should the dose of inhaled corticosteroid be decreased in such patients?
No.
There's nothing like that.
Nothing like that.
Dr. Munjan, what are the steps in the management of osteoporosis? Would you like to give calcium, vitamin D3 daily, weekly, monthly? How long? Please, for the audience, clarify on this topic.
As far as calcium is concerned, we give daily doses because 1000 milligram per day is the requirement, and it is slightly more in pregnant ladies and children. And as far as vitamin D is concerned, to make the compliance more, we prefer to give vitamin D weekly. And normally we give 60,000 international units every week, and we give for about 8 weeks, and after that I prefer to give one capsule or one sachet of 60,000 international units every month.
For how long the patient can continue to take calcium? Indefinitely?
Yeah, because if it is given in the required dose, then I think there is no harm in taking calcium indefinitely.
Dr. Wonder, is it a myth that long-term intake of calcium can lead to calcification of the arteries, or is there any truth in it?
I think that's a myth actually, but I would like to, I don't know whether you have others, but at least I would like to, of course we have hyperparathyroidism as a common diagnosis, but iatrogenic hypercalcemia can play havoc with people, and hypervitaminosis D we are seeing and diagnosing so frequently. So we should be little bit cautious in terms of this excessive over usage of vitamin D as a supplement. And calcium supplementation alone has very little role to play, especially in males. And on a lifelong basis, it's not a supplement. It just goes waste actually. So I would not advocate calcium supplementation unless your patient needs it on a routine basis. Although it doesn't cause any coronary or any calcification.
So there are two calcium messages contrary to the belief. It is a myth that coronaries get calcified with long-term calcium, and on the other hand, as in general practice, most of us are giving calcium indefinitely, and that is also to be avoided. Am I right? And Dr. Malli, if oral biphosphonates are given, they are associated with the best. So there is a cross call on you can know what I am saying. So please clarify the patient being biphosphonate, varices esophagitis, like PPI, again osteoporosis. So how do you deal with it?
The oral bisphosphonates, there are two issues. One, they are per se an irritant drug, so they need to be taken with a good amount of fluid in the sitting position. So when we talk about pill esophagitis, if we see the chart in all the textbooks, the two drugs which have been classified there, one is doxycycline and other are all these bisphosphonates. So because the reason is they are really irritant drugs, and if you take too little of fluid and it gets retained in the esophagus, it can produce real bad ulcers, which can produce bad dysphagia or anaphagia, and recovery might take a couple of weeks. So they need to be taken with liberal fluids in a sitting pose. So that's one thing. Two bisphosphonates, they do increase reflux episodes also. And that is how people who are long-term therapy, they have a twofold higher chances of paralysis. But does that mean that all people on bisphosphonates, they should be on PPIs? This is still an ongoing controversy. But if someone with bisphosphonates does experience reflux symptoms, PPIs should be the first line drug in those patients. So in those people, you can go a concomitant once a day PPI plus weekly bisphosphonate therapy.
One thing for Dr. Karali, before we close it, there should be some prevention of diabetes. As you have said, diabetes, India is going to be capital of diabetes, and China is also going to be capital. How we can prevent it? We know only two things, that is lifestyle and diet. What other to add? So many panelists are sitting and they some carry on message for us.
I think the lifestyle modification comes for the foremost: weight reduction, active exercise, decreasing carbs. That is the main thing which is the latest to that. Carbohydrates more than fats, they are harming ultimately as far as genesis of diabetes and of course drugs, corticosteroids, long-term corticosteroids. So these are the things we are, apart from that weight reduction. So all these non-communicable diseases, they are comprising of metabolic syndrome, they have all these things in common. So carry-home message is that a good lifestyle, decreased weight, active participation in aerobic and other exercises, balanced diet, and non-intake of steroids or other drugs at random should be preventing you from diabetes in case you are not having any genetic predisposition for that.
Can I add please? The fetal origin of adult disease is not just a theory, it is a reality, and the future generation that is going to come, so that that generation does not develop all the metabolic complications is very, very important. The word coined by the Foxy president this year is Adbhut Matritva. It is not something to fun about, but it is actually what is required that we focus on all our pregnant women, and so that the coming generation is not affected. Another thing that I also want to say is that what I have learned sitting here is that so many drugs that we are prescribing, somewhere or the other, they are also leading to other problems. NSAIDs, we are dealing with something, we are treating something, and we are leading to another disease. So, and this discussion about calcium, I think I really want to have my say before I leave this place is, let us only prescribe what is actually required.
Yes.
It's not necessary
That is the point.
that we have a very long prescription which, because it carries an NSAID, should have a PPI, because it carries a doxycycline, should have a PPI, just because the woman is coming to me, I should give her a calcium. I don't think that is required. Let us just treat our patients for the problems that they have. Let us talk to them, give them those 2 minutes which they really deserve because they are paying our fees. Because if we as doctors do not make our patients aware, then I think what my teacher used to say is, जो बंदा तुम्हारे सामने बैठा है, अगर वो तुम्हारा रिश्तेदार होता तो उसके साथ कैसे डील करते? I go by that principle. I think a lot of us who are not doing it should actually start doing that.
Just to let me know, the PPI is inhibited calcium and magnesium absorption. They lead to hypocalcemia, hypomagnesemia, cause a lot of cardiac arrhythmias and cardiac failure can occur, and then we give diuretics, they further complicate the problem. So I think we have to be very well aware of all these things once we are dealing with the thing. But finally, I would like again back to Dr. Gordon. How do we deal with such patients? Hypocalcemia, hypomagnesemia leading on to cardiac arrhythmia, CCF and...
Actually, I would like to add to what she just said. For primary prevention, actually, you must all be aware, patients come and ask us, Doctor, was aspirin khaliye ji? And aspirin has been propagated as a primary prophylactic agent for a long, long time. 2-3 months back, there were 3 trials in the New England Journal of Medicine. And it's very rare to have 3 parts of one trial on aspirin usage. And aspirin as a, you will recollect the American Diabetes Association at one time said that since diabetes is a coronary artery disease equivalent, we should give aspirin to all these people. Now all these are negative trials. So aspirin as a primary preventive agent in these 3 subset of this ASPIRE trial, it's a negative. So a lot of these agents which we have been, there was a very famous nurses health study which at one time propagated that if you use aspirin for prophylactic purposes, it can prevent coronary, but none of these, but for statins, actually there is no, we were discussing diabetes prevention and Karanveer so beautifully answered that it's for all lifestyle acquisition diseases, the best way to prevent them is lifestyle modifications.
So, no. It's a secondary prevention, not for primary. So, finally, last word from each of my experts, because all these topics were interlinked, they were intermingled, and we know every specialist faces the problem of other specialists. So, any comments from my enlightened audience or my expert colleagues regarding what we have discussed before we wind it up? Anything, Dr. Wonder, Dr. Malli?
I would like to say we had the best moderator today and the best person.
I'm really honored. So,
Stress level, and other is pollution in the prevention of diseases.
it's very well taken. I always feel, although it's very much less documented, these 2 points, pollution and stress, in the day-to-day life of metabolic syndrome also play a very important role. Really, absolutely right. Thank you very much. Good night. Thank you very much.